Okay, so we're going to get started with our next speaker. Our next speaker is Dr. Celina de Borja, a pediatrician with special training in sports medicine who cares for children and young adults with a wide variety of musculoskeletal conditions. In addition to general pediatric orthopedics, her areas of interest include sports and dance medicine, and injury prevention and bone health. Originally from the Philippines, Dr. de Borja earned her medical degree from the University of the East, and she completed her pediatric residency through Hackensack Meridian Health at Jersey Shore University Medical Center, and then completed a fellowship in sports medicine through Harvard Medical School at Boston Children's Hospital. Dr. de Borja is the director of the UCSF PlaySafe program and is the team physician for Balboa High School in San Francisco, who's making a run for the state bracket for football tomorrow at 12:30, so tune in. Not that it's going to be televised or anything, but still. And I have the honor of working with Dr. de Borja at the Redwood Shore Specialty Clinic at least once a week. So please welcome her as our next speaker.
Thank you, Katie, for that kind introduction. So thank you everyone for joining this session today on sports physicals. I do not have any financial disclosure relevant to this talk. So the sports physical is based off of the PPE monograph. The most recent version is the 5th edition. It was published by the American Academy of Pediatrics. It was written in partnership with the American Academy of Family Physicians. And it's written in collaboration with the sports organizations such as ACSM, AMSSM, AOSSM, AOASM, and it is endorsed by the National Athletic Trainers Association as well as the National Federation of State High School Associations. So the sports physical is more than just a chore for our student athletes, their parents, and our primary care providers to do every year. It has specific objectives. First, it aims to determine the general physical and psychological health of our student athletes. Next, it evaluates for conditions that may be life-threatening or disabling. It also aims to evaluate for conditions that may predispose to injury or illness. It provides an opportunity for discussion of health and lifestyle issues. And lastly, and very importantly, it serves as an entry point into the healthcare system for adolescents without healthcare home or medical home. So we serve children from underserved communities, resource-limited communities who barely see their primary doctor or clinician. And sometimes these sports physicals are their main way to see a doctor each year. So the logistics for the annual sports physical include the following. Ideally, it is performed in an athlete's primary medical home, as primary care providers typically have access to their prior medical history and current medical conditions. Ideally, this is performed 6 weeks prior to the beginning of the season to allow both the family and the providers some time to initiate any evaluation or interventions that may be necessary before the season begins. And for frequency, this is something that's determined by state. For us here in California, we base it off the CIF, or the California Interscholastic Federation. And when you go on their website, unfortunately, frequency is not well established. And so with that said, because frequency is not agreed on, I think the reality is we don't really know what the best frequency for these things are. However, since children over 2, adolescents and young adults are recommended to see their primary doctor annually anyways, it will be reasonable to incorporate these PPE questions and evaluations into their annual health supervision visit. And so the PPE has 3 main components. There's the medical history, there's a physical exam, and then there's the sports clearance. We'll start with the medical history, as it detects about 90% of medical conditions and about 70% of musculoskeletal conditions in student athletes. We encourage to involve parents and guardians when doing these physicals for young individuals, as there are details about their past medical history, especially during their early childhood, that these student athletes may not be aware of, as well as information about their family history that they might not be aware about. And then also importantly, the sports questionnaire may involve some questions that are quite sensitive. And so maintaining confidentiality with adolescents is also recommended. So the medical history starts out with a comprehensive review of medical records. So their medical and surgical history, list of medications prescribed or over the counter, as well as their allergies and immunizations. And then it goes on to include this extensive questionnaire that I am sure most of you have seen in your practices. But these are a 2-page questionnaire that have 4 main sections. And so there's a big section on heart health. There's about 2 questions for bone and joint. There's a lot of questions on medical conditions that student athletes may have pre-existing. And then there's questions specific to female athletes. One special addition to the most recent version of the PPE is a mental health screen, or the PHQ-4, that you can see at the very top of the table. It's 4 questions that could screen for anxiety or depression. That's been recommended we include from the 5th edition. And then this is what the physical exam section looks like. So it starts out with basic measurements. So height and weight, which we typically gather during our annual visits anyways. It includes vital signs, so blood pressure, pulse. It includes vision assessment. And then it has 2 main sections. There's a medical and a musculoskeletal section for it. For today's talk, since we're going to be focusing on red flags, we're going to focus on physical exam findings that may point towards issues related to cardiovascular issues, so general appearance and cardiovascular exam. For the MSK exam, it does look like a lot, but typically it's just a range of motion and strength test from head to toe. There are a lot of guidelines or videos that show the 2-minute MSK exam, just checking on range of motion and strength. But it's also helpful to know that there is a functional movement screen at the bottom of the sports physical. It includes some movements such as double leg squat, single leg squat, or jumping and landing tests. These tests could be helpful for looking for any deficits in neuromuscular control or any risk factors for further injury, which I'll share a little bit more about in the next slides. And then comes the last section, which is the sports clearance, and this is what it looks like. So there's 5 categories which you may choose from, which athletes may belong to. So about 90+% of athletes will be cleared for sports. It's just a matter of, are they cleared without restrictions, or do they need any other recommendations? About 15% may need some evaluation or intervention. And it's very rare to not clear a student athlete for sport. So first category is medically eligible for sports without restriction. That's someone who's completely healthy, no prior issues, no current complaints, and no red flags. Second category is medically eligible for all sports without restriction with recommendations for further evaluation or treatment of ... So one example I could think of is, someone who's healthy, not currently having any issues, but if you notice maybe prior history of recurrent ankle sprains or overuse injuries with every sports season, maybe you can recommend a form of rehab or injury prevention strategy that can help with this upcoming season. So they're still cleared, but there are some recommendations. The third category is medically eligible for certain sports. So one specific example I have of this is a teenage athlete who is a swimmer, actually, who met me for some shoulder overuse injury. As we were talking about other activities that she can cross-train with, while she was recovering from these overuse injuries, she mentioned to me that she had history of retinal detachment. And so she shared that, she could only participate in non-contact sports because of that medical condition. So in that case, that individual would fall under this third category where, they are medically eligible for certain sports, and you can list down there, non-contact sports only due to medical condition. Fourth category is not medically eligible pending further evaluation. Sometimes these are the kids where they have some red flags in their heart health eval that you might want to seek consult from a cardiologist first before clearing them. And then last would be not medically eligible for any sports, which again I find very rare in practice. One might be, say, someone recently sustained an ACL injury and they're post-op, and they're just not quite done with their post-op protocol yet, and so you wouldn't clear them for anything at this time until they're cleared by their orthopedic surgeon. So sports clearance decisions should be based on pertinent clinical guidelines. The AAP, Council on Sports Medicine and Fitness guidelines is highly recommended that we use this in letting athletes know how to proceed with these steps. There's also resources from the American Heart Association and the American College of Cardiology for any athletes with cardiovascular conditions. And so I know this slide isn't the clearest, but I just wanted to show a snippet from these two articles on the page. So the first article cited on the top left corner of the screen is the landmark article. It's medical conditions affecting sports participation. It was written back in 2008, and it has like a 4-page table listing out different medical conditions that you can encounter individuals who would like to participate in sports, and it has some guidance on how to proceed next. So it does have some guidance on whether or not they need further evaluation before full clearance, things like that. It includes things as simple as viral gastroenteritis to, cardiac issues and mono and other conditions that you may find in individuals. Although this clinical report was retired in 2018 when it, passed 10 years, the table is still relevant as it is still referenced in the article on the bottom right corner, the sports pre-participation eval published in 2019. So these two articles are open access. They're available online, and you can use them as a resource when you're trying to figure out if your patient with a certain medical condition can participate in sports or not. Other tables that are included in these articles are these two tables that I think could be very helpful. So again, on the table 1 shows classification of sports depending on contact or non-contact category. So again, that teenage athlete that I mentioned couldn't participate in contact sports, right? I was trying to look for other activities for her to do while she was resting her shoulder. So we kind of went through this list of non-contact activities that she might be interested in. So it's not that, she's restricted from swimming because of her shoulder injury and she has limitations because of her medical condition that she's restricted altogether. There's still other things that she can do if she wants some physical activity. The table on the right categorizes sports depending on their intensity, and typically see these used in patients with some cardiovascular conditions. And so it categorizes sports between high and low intensity, and typically the cardiologist has recommendations on where they're at anyways. And so again, another table that we can reference if you're trying to help your patients out. And so we move on to the main topic of this talk, which is red flags. So we're not going to go through all medical conditions and all the other objectives of the sports physical, but we'll focus on objectives 2 and 3. So evaluate for conditions that may be life-threatening or disabling, and also evaluate for conditions that may predispose to injury or illness. So we'll start with heart health. Heart health is really important in the sports physical, that it includes about a third of the questions in the checklist. And that's because sudden cardiac death is rare, but is a devastating event. The difficult thing about sudden cardiac death in athletes is that most athletes who are at risk are going to be asymptomatic. And so it's so difficult to identify who's at risk. This topic is quite controversial. At this time, universal EKG screening is not currently recommended by the AHA or AACC for athletes 12 to 24. So in your practices, if you are doing a sports physical and you're just during routine screening, someone's overall healthy, you don't necessarily have to send them for a consult or order anything extra if there's no red flags. Targeted screening for high-risk population is gaining acceptance, and that's what this talk is really all about, is like identifying red flags or risk factors that may lead you to seek further consultation. And so, as I mentioned, a third or 10 out of the 30 questions of the checklist asks about heart health. So you want to look out for athletes who report exertional chest pain, shortness of breath, lightheadedness, palpitations, syncopal or pre-syncopal episodes, unexplained seizures. Other details that could be helpful as well come from their past medical and family history. So this is where it's important to involve adults in this conversation. So prior history of heart murmur, a lot of children have physiologic murmurs during early childhood that they may not be aware about, if they're a young teenager, but their parents are going to be aware about those. History of any blood pressure issues, any reason that they've been restricted for sports in the past. Again, 90+% of student athletes are going to be cleared. So if there's ever been a reason that they were restricted for sports, that is something that should require further discussion. And then prior workup for heart health. So again, we don't recommend routine screening, EKG or echo for individuals who are healthy. So if anyone's had an EKG or echo in the past, you may want to ask as to why they've had that done. And then for family history, we asked about history of sudden or unexplained death, heart attacks, especially for family members who are less than 35. And then for physical exam, pertinent findings for heart health include Marfan features. So typically when I, hear the word Marfan, I think about, very tall, very long, very slender, lean, long arm span, right? Those kind of features. We also find musculoskeletal findings in these individuals. So they typically have a pectus excavatum or sunken chest. They may have scoliosis or flat feet because they're ligamentously lax. And because some of them will have some ocular abnormalities, they may have these thick glasses. And then auscultation for heart murmurs. Because one of the more common causes of sudden cardiac death is HOCM, which is best evaluated in both supine and standing positions, we recommend performing your heart auscultation in both supine and standing positions to differentiate between pathologic and physiologic murmur. And then checking their blood pressure is also helpful, making sure they're in a properly positioned, quiet, relaxed seated position. If there's any concern that there's any errors in measurement or say, maybe white coat hypertension, I would just kind of repeat it in the office to make sure that we get most accurate measurement. And then checking the pulses, so both radial and femoral pulses are recommended, especially in the setting of elevated blood pressure, because sometimes these maneuvers can help exclude things like coarctation of the aorta. And so let's talk briefly on Marfan syndrome, because for some reason it's, always mentioned in the physical exam. It seems to have been singled out of all the medical conditions. So, it makes you wonder what's the big deal about it. So, Marfan syndrome is a connective tissue condition that's genetic, which involves a lot of different organ systems. So they can have cardiovascular association, ocular association, bone and joint association. And so certain individuals with Marfan syndrome may have aortic or mitral valve conditions. And so intense exercise for them may increase their heart rate, increase their blood pressure. That could put added stress to the aorta. So that's one of the main reasons why we're, very carefully evaluating for these things. In addition, any injury to the head or close to the top of the body may lead to, worsening of their ocular conditions, such as lens dislocation or retinal detachment. And so we typically avoid contact sports for these kids. And then excessive stress on the bones and joints can lead to added pain or instability issues, such as shoulder patellar dislocation. Lastly, because some of these individuals could be taking medications such as anticoagulants, they may have increased bleeding risk as well. So something to think about when you're thinking about the type of sports they participate in. Moving on to murmurs. So there's a lot of different type of murmurs out there that reflect different types of cardiac condition. But for the purpose of this talk, we'll focus on the two main things that we, differentiate when we're doing a sports physical. So that's the HOCM murmur versus the physiologic murmur. The HOCM, or hypertrophic cardiomyopathy, is from a left ventricular outflow tract obstruction. It typically presents with a systolic murmur heard best at the right upper sternal border. It's typically harsh, loud, grade 3 or louder. And the unique feature about this type of murmur is that it increases with standing or Valsalva maneuver. So you may hear it in supine position, but it's louder when they're standing or performing Valsalva maneuver. That is in contrast to a physiologic murmur, which you may also hear in our young athletes. It is also an early systolic murmur heard at the upper sternal borders. This murmur is typically softer. And although you can hear it during an upright position, it increases or becomes louder when they're supine. So it's the opposite presentation. And then next, we also check at blood pressure. So this table is based out of the clinical practice guideline for screening and management of high blood pressure in children and adolescents. As you can see, the normative values for blood pressure in children are a little bit more complicated because they're in percentile. However, for most of the student athletes that will do sports physicals for, anyone 13 and above, their normative values are about the same as adults. So, hopefully it makes things simpler. So normal BP is less than 120/80. There's a category that's considered elevated BP, and then there's stage 1 and stage 2. At this point, there's no data linking hypertension to sudden cardiac death, so the recommendation is to clear athletes with elevated BP or even stage 1 hypertension, plus provide them with the appropriate evaluation and management. So if it's diet and lifestyle modifications with BP checks every 3 months or so, that could be a good start. If things are persistent and there's other comorbidities, you may manage them medically, but they may participate in sports. The one category where there's sports restriction is stage 2 or greater. So that's when you want to manage them first, bring their blood pressure down, stabilize them before they're able to participate in sports. And then I think lastly for heart health is the pulse check. So what this really checks for is a condition called coarctation of the aorta, which is a congenital heart defect. Historically, coarctation is one of the more common heart defects that's missed during the neonatal period. However, with more recent routine screening procedures in the newborn nursery, I think we're seeing less of them undetected in older individuals. And so coarctation is a condition wherein there's a narrowing or a kink in the aorta after the blood has already been delivered to the head and the upper extremities. And so these individuals may present with some red flags in their history form. And so they may report exertional chest pain, fainting spell, sudden shortness of breath. On physical, they may have unexplained blood pressure. And because of the location of the narrowing, they typically will have high pulses and higher blood pressure in their upper extremities, and then lower or weaker pulses, lower blood pressure in their lower extremities. So that's kind of why it's recommended to also check for, pulses in addition to auscultation and blood pressure. And then this is the summary of the recommendations from the American Heart Association. So it points out all the red flags that you can get from the personal history, past medical history, family history, and also some details from the physical exam that you may consider as red flags. The AHA does recommend that any athletes with suspected or identified risk for sudden cardiac death to be evaluated by a cardiologist prior to clearance. All right, so moving on to bone and joint. So bone and joint is very short in the sports physical. It only really asks of two questions. There's prior or current musculoskeletal injuries. Obviously, if there's a current musculoskeletal injury, you'd want to address that first before clearing them, especially if it will affect their sports participation. But typically, when these sports physicals are performed, it's like prior to the season, and so they're typically well or uninjured at the time. So what I pay attention to are history of recurrent acute injuries. So, for example, repeated ankle sprains, from a sport like basketball, or repeated or recurrent overuse injuries. So, for example, runner's knee, from soccer or basketball. Because I use this as an opportunity to maybe discuss some injury prevention strategies that they can utilize to help them with this upcoming season. And then another area where I also spend a lot of time with, and this is mainly with my interest in, bone health, is, details pertaining to history of multiple fractures. So typically we categorize kids less than 10, if there's been 2 fractures or more, we think of that as, too many, for that age group. And then typically it's like 3 or more when they're in that adolescent age. Or a prior stress fracture, because these two features in someone's history may reflect other problems, outside of just sports in general. So there could be biomechanical issues, so extensive load or overtraining or poor mechanics, but there could also be biologic issues. So any medical issues, for example, GI leading to malabsorption, renal condition, endocrine condition that can impair their bone health, might be discovered, through these conversations. And then lastly, something that could be more subtle, some behavioral issues such as eating disorder that sometimes first present as multiple fracture or prior stress fracture. And then the physical exam, again, it's a 2-minute MSK exam typically is when we do it. It's range of motion and strength, top to bottom. And then functional movement screen, could be helpful in looking at any deficits that could lead to, injury. So there's double leg squat or single leg squat depending on their athletic ability. You can also have them do like a, jumping and landing test depending on the space in your clinics. Ideally, they have good, form and alignment. If you're noticing that their knees collapse in, so like knees turn into valgus when they're doing their jumping and landing or squatting activities, these may reflect some deficits in core strength or pelvis strength, and may reflect increased risk for lower extremity injuries, specifically patellofemoral pain or ACL tear. So even if they're asymptomatic or even if they don't have any major complaints, I use this as an opportunity to promote cross-training, strength training, balance training, or any other injury prevention strategies that could be helpful. And so if you encounter someone with recurrent acute or overuse injuries, feel free to send them to us in sports medicine to discuss options. You may also send them directly to physical therapist for some rehab. And then for those with multiple fracture history or prior stress fracture, you may also want to consider sending them to a registered dietitian for some nutritional counseling or a mental health specialist if you think there's some disordered eating going on. All right, so switching gears to mental health. So mental health conditions aren't uncommon in the student athlete population. Studies show that 50% of athletes or individuals show their first signs of some mental health difficulties by 14, and 75% their conditions begin to manifest around 24. And although early intervention can help prevent negative functional outcomes, less than 20% of children and adolescents receive treatment for these issues. And although sports, physical activities in general could be protective of, mental health conditions, sometimes the competitive nature of sports or personality traits such as perfectionism or just the athletic culture, can help contribute to developing these issues. In addition, injuries may trigger or unmask mental health conditions and may also influence their recovery, including their postoperative outcomes. It is important to know that underreporting may be higher in student athletes, and that studies show that in female athletes, they sometimes prefer to disclose these issues with clinicians of the same gender. So if you feel like your athlete is just not, you have a hunch that something's going on, but you just feel like they're not opening up to you, then it might be helpful to introduce them to a colleague who might be able to help. Like I mentioned earlier, a mental health screen was included in the most recent version of the PPE. It's the PHQ-4, which screens for anxiety and depression. There's only 4 questions, so it should be very quick. And there's specific instructions at the bottom. So the first 2 questions are for anxiety, the last 2 are for depression. And the instruction says if anyone has a score of 3 or greater in each subset, there are recommendations to pursue other, screening modalities. In addition to the PHQ-4, some of the questions in the medical history also screen for body image dissatisfaction or disordered eating. So question 25 asks, do you worry about your weight? 26 asks, are you trying to or has anyone recommended that you gain or lose weight? 27 asks, are you on any special diet? Do you avoid certain food groups? And then 30, have you ever had an eating disorder? So definitely these questions, may require further conversation, but they may be helpful to allow you to think about other resources such as nutrition or mental health. And then lastly, female athlete. So the female athlete triad is this phenomenon that was once first described in 1997 that reflected this phenomenon in female athletes where they would get stress fractures, they would lose their periods, and then they would also have some eating disorder. Over time, the definition of the female athlete has evolved, wherein they don't have to have amenorrhea to qualify as female athlete triad. They can just have irregular periods or missed periods, and they don't have to have a full-on eating disorder to qualify. More recently, in the last 5 to 10 years, we realized that the female athlete triad are just small components of a bigger picture called relative energy deficiency in sport, which is commonly known as RED-S. So RED-S is the wheel that shows that bone stress injuries, stress fractures, multiple fractures, and menstrual irregularities are just 2 pieces in a bigger pie that involves other organ systems that all stem from low energy availability or under fueling. And so with that, some questions in the PPE help figure out if any female athletes are having any subtle symptoms. So they ask about age at menarche, but more specifically, it also asks about how many cycles they get in 12 months. I think it's very important to ask the number because not everyone is aware of what regular or irregular means. It is true that cycles sometimes are shorter or longer depending on the individual, but the magic number for this versus 9. If an athlete, especially during their peak sports season, is having less than 9 cycles a year, and their cycles are disappearing during their sports season, that could be a sign of underfueling or low energy availability. And so for a female athlete and mental health issues, we highly recommend a multidisciplinary approach. And so we encourage normalizing discussions on mental health and nutrition and transparency with limitations and encouraging referrals. So typically these things are addressed through their primary care visits, as you know them best and you see them most frequently. So you're like the frontline clinicians for these athletes. But we do recognize, the value of our athletic trainers also on the front line, who meet them in the schools, in the training rooms, or in the sports setting, who may be the ones urging them, to see a clinician. As sports medicine specialists, we work very closely with physical therapists, as well as registered dietitian and mental health providers in helping these student athletes achieve, overall wellness. And so before I end, I'd like to share some resources that could be helpful in your practices. PPE Monograph is available online. It's published by the American Academy of Pediatrics. We also have a lot of resources for stretching and strengthening injury prevention programs in our UCSF Sports Rehab website. And then lastly, we have a mental health toolkit that's published in the CIF website that's written by one of our colleagues here in primary care sports medicine. And that's it for me this afternoon. Thank you so much for joining me in this session on sports physicals. And if you'd like to learn more about pediatric musculoskeletal conditions and sports medicine, we have another course in March. It's also a multidisciplinary course with physicians, athletic trainers, physical therapists, and other healthcare providers. Day 1 would focus on pediatric orthopedic conditions of the hip and some neuromuscular conditions. And then day 2 would be pediatric sports medicine with exciting topics such as AI, female athletes, strength and conditioning, nutrition, mental health, Stroth PT, and then we'll do some motion lab tech demos in that course as well. So we hope to see you there. Thank you.
Does anyone have any questions for Dr. De Borja?
Yes. Yes. Sure. Yeah, I know. I think that's where the question was, someone's already playing or already in season, asymptomatic, I guess. But, on exam, there was a murmur. I think that's, definitely an individualized approach. I know it's very hard to just keep him out. I think if that murmur is associated with other red flags, so like exertional chest pain, shortness of breath from the history, or if there's any red flags, say in the past medical or family history, that might strengthen your decision to hold off on sports. But if, for example, it's just a murmur and they're overall well and their history and the rest of their physical is pretty clean, then I would say it's reasonable to continue participating in sports while referring them, for a cardiology eval. I know that's like a difficult fork to take when you're already at the peak of the season.
Okay, we'll take one from the Q&A on the app. It says, can you comment on activity restriction for adolescents with suspected Red S, and what's your threshold to restrict?
Oh, good question. Yeah, so for Red S, the activity restrictions are typically when there's clinical eating disorder. Specifically if their eating disorder is causing some abnormalities, say in their cardiac exams or their vital signs, their blood pressure, or sometimes they may have electrolyte imbalance. So typically, when eating disorder is so severe, that's when they're restricted. If it's just under fueling, but not necessarily like a full-blown eating disorder, typically we allow them to exercise and kind of guide them on avoiding overtraining and make sure they make up for what they're losing, which is the under fueling. Yeah. I guess if they have another condition, say like they're an active stress fracture, that would be a reason to activity restrict. We do have protocols for those things of no sports for, say 6 weeks, followed by like a rehab protocol. But outside of any condition like a stress fracture or like a severe eating disorder, typically if it's just under fueling, we allow them to exercise. Yes. Sure. Yeah. So I understand there, could be limitations, right? With like our office space and equipment and performing these functional movement screen. And so, yeah, typically it's like a foot or so of like a step, and then you just have them kind of, jump off it and land. If you don't have those equipment, not a big deal. Typically a double squat test and a single leg squat test will show those deficits anyways. For the more athletic individuals, I challenge them with a single leg squat test. And then for those who are maybe younger and not so athletic, you'll see it right away. If you ask them to squat and their knees like collapse in, you're like, I think you need to work on your hip and core strength. Yeah. Yes.
Can you talk about mild head injuries, maybe things that don't stand out as concussions, but things that have multiple?
Oh, multiple head injuries, prior concussions, is that right? I think that's an own talk of itself. I see Dr. Sander in the back. We have, I believe, concussion sessions for this course, so I don't want to overstep. But typically I just want to make sure they're aware of what a concussion is, and they're not recognizing concussions when they happen. I think that's awareness is key for prevention. Making sure that they've disclosed their concussion, they're seen by a clinician, whether it's primary care or a specialist, and they have been managed appropriately. And so if the management seemed reasonable from their primary care, then I'm okay with that. We can just kind of move on, towards the kind of next steps. And then it's for me, really, it's a lot of like education and counseling. If it's not active, is that what you're saying? Like it's not actively an issue, but they have history of prior injuries. So yeah, I think making sure they know what a concussion is and they understand if they've been concussed in the past and they know who to reach out to is kind of the counseling that it provides.
Can we take another one from the chat here? It's if there's a sudden early death in the family history, should you send the athlete to cardiology for clearance?
Yes. Yes, we do. Yes.
Kind of piggybacking off of those other two questions.
Yes.
The one on concussion, if there's a history of, say, 2 concussions, 12-year-old
Sure.
kid in the past year, 2 different events.
Yeah.
Do you write that on the form?
Yeah.
Still clear them, but
Yes.
that way it can be tracked.
Yes.
So that people know this kid
Right.
has had 2 concussions already.
Yes. Yeah. So I think that's definitely reasonable practice. So, document year, concussion number 1, year 2020, concussion number 2, year 2022. Document, say, completely resolved, completely asymptomatic, normal physical exam. And then that, if it's not an active concussion, you can clear them.
Okay, and then second thing, you mentioned that when they don't pass the functional squat test,
Sure,
for instance, or the jump test, are you educating them right there how to do it properly, or are you sending them on right away to PT?
There's two, either way is reasonable, and it really just depends on like the kind of the maturity of the student athlete, or say like access to resources. And so we do have a lot of exercise resources online that I share with them. Like I give them the handout and the link to the website. And so I also encourage you guys to like have that as a resource in your practices. It's in our sports medicine website. If there may be like an older high school athlete who understands these exercises and will try them out, I think it's reasonable to just provide them a home exercise program. If you think that, maybe they're younger or there's any issues with compliance or consistency and the parents are concerned that, every soccer season we're here with jumper's knee or runner's knee, it just keeps going on and on and on, then definitely, refer them to a physical therapist or more professional, driven, supervised rehab or injury prevention protocol. Yes. I guess if so I guess I would only get the EKG if they have any red flags, if the red flags I get, like depending on that like little guideline, if the red flags are fairly soft and your EKG I guess is like reassuring, then that might be enough to reassure you from primary care. But if you think that the red flags are just too many and it's just something that you want your cardiology colleagues to like comment on, then I highly suggest it. So I would base it off of the AHA guidelines for sure.
My clinic had been told during COVID that if a pediatric patient had like any significant COVID illness, they needed to get sent PEDS cards because of possible cardiomyopathy fracture COVID. Is there any validity to that still, or are you worried about that?
Not in the recent years. Yeah. Not in the recent years. Yeah, I guess if I remember correctly, if they had moderate to severe COVID, especially if they've been hospitalized, intubated, then I think those are the ones that had higher risk for cardiac issues post-COVID. But more recently, the COVID infections that I'm encountering are very mild URIs. I don't think the mild URIs ever needed the cardiac eval anyways. So yeah, I guess like moderate to severe, I would just kind of follow that. Yeah.
Alrighty. Thank you all.
Thank you, everyone.